So I'm going to talk about the right ventricle, and from a little bit different perspective than most of the other talks, and frankly, from the different perspective from the way I usually talk about congenital heart disease in the fetus. I'm going to give you sort of more of an anatomic, pathologic spin on it, and so I will use some different types of diagrams and then show you what the pathology looks like in the fetus. So first, we're talking about just the right ventricle here. I'm not going to talk about the AV junction. That was just covered quite well. This is, if you were to open the ventricle like a book, this is the right ventricle, this is the right ventricle. Seems like it should be pretty simple, but in reality, the right ventricle is a very, very complex structure. There are people in pediatric cardiology who devote their entire lives, not careers, but lives, to the right ventricle. It takes on not a conical shape like the LV, or like you would think from looking at this type of pathologic specimen, but much more complex of a shape. And so it's very interesting, but also very difficult to image. And then on top of that, the function of the right ventricle has been shown to be quite complex, as opposed to the left ventricle, where the fibers are sort of circumferential and sort of ring like a towel when the ventricle is squeezing. The right ventricle has this much more complex fiber orientation, and so it's just a fascinating structure. But I need to simplify it a little bit because I only have 30 minutes. So we will talk about the right ventricle in terms of its segments. And we usually think of the right ventricle in terms of an inlet, a body, and an outlet. So a right ventricle is thought of as being tripartite. Now, our go-to view, of course, is the axial four-chamber view. We've already talked about this quite a bit, about looking first at the position, axis, size of the heart, size of the chambers, their symmetry, and the atrial and ventricular septi have already been covered. Of course, function and rhythm on a cine clip. We need to delve even deeper into the evaluation of the ventricle, though, than just that still image of the four-chamber. And again, this was already elegantly covered by Tracy and Elena, looking at atrial morphology, the tricuspid and mitral valves, the AV junction, the ventricular anatomy, a functional assessment, the pericardium, the posterior left atrial space, descending aorta, and paraspinal region, as well as the lungs. All detailed assessment is necessary on the four-chamber view. We're going to concentrate, though, on just the right ventricle for the next little while. So looking at the crux of the heart, also already discussed that there should be a little bit of an offset between the septal leaflet of the tricuspid valve and the anterior leaflet of the mitral valve. And also morphologically, there should be a moderator band in the right ventricle, and then physiologically, the atrial septum should bow from right to left. And I consider this to be a ventricular type of structure because compliance of the right ventricle helps to determine when the shunting happens between the atria. So this reflecting ventricular function. We also need to look at the sagittal view, though. As I said, the right ventricle is a complex structure, and you cannot just look at it in the four-chamber plane. And so knowing the details of the sagittal view, very important for assessing the right ventricle. The sagittal view can also tell us about the atrial arrangement and the foramen ovale direction. We also see the base of the heart, the infundibulum of the right ventricle, and the valves, as well as the ventricles themselves, the aortic and ductal arches, which will be the topic of tomorrow. So those two views help to really give you a clearer picture of what is actually a complex three-dimensional structure. So those will be our go-to views. There are also some sagittal imaging that's necessary in assessing the right ventricle. Here we are looking at the infundibulum and pulmonary valve. And with just a little bit of a move of the transducer, we'll get the short axis of the ventricles where we can look more at the body of the right ventricle. So first, let's talk about the inlet, which is this portion here. From the diagram, you could see that this is a very complex interplay of ventricular muscle as well as tricuspid valve, both the annular attachment as well as the chordae tendineae and papillary muscles. There are normal attachments to the septum as well as to the outlet septum. This is the papillary muscle of the conus or the muscle of Lancisi. This is a normal structure here, and this helps to make the leaflet, the septal leaflet of the tricuspid valve, that septophilic, septum-loving leaflet that Tracy talked about. So this entire apparatus I would consider part of the inlet, and echocardiographically, of course, it's going to look something like this. So what can go wrong with the inlet? Well, first let's talk about Ebstein's malformation, which is a displacement of that septal leaflet. It is not necessarily a displacement of the posterior leaflet, although it can be. And what's not shown here is, coming out of the screen, the anterior leaflet is not displaced from the annulus. Rather, it may become sail-like and redundant, but it's not generally displaced. So a displacement of the septal leaflet required for Ebstein's, and then variable amounts of displacement of the posterior leaflet with the so-called atrialized right ventricle. This is very easy to miss, and one of the first case reports that I participated in years ago was actually missing this because the annulus of the AV valve will still be there. There's a junction between the atrium and the right ventricle, and the right coronary runs in it, and that is still there even if the valve tissue is displaced. And so a still frame of this would be very misleading. But this patient indeed has Ebstein's, as we can see if we add color Doppler. This is pretty messy. Of course, you'd want to clean this up. But the point being that the tricuspid regurgitation jet starts way down here in the apex of the ventricle. So that tells you that you've got an issue with displacement of the leaflet. Now, sometimes Ebstein's looks like this. Of course, you're not going to miss this with the sequelae of this tricuspid regurgitation leading to massive right atrial and right ventricular enlargement. But in this fetus with Ebstein's, not quite so obvious. Very subtle right atrial enlargement. And the right ventricle actually looks okay. Pulmonary arteries may be a little smaller than the aorta, but this is clearly Ebstein's. There's no septal leaflet here. The septal leaflet is actually way down here. So how do you avoid making or missing that type of displacement of the septal leaflet? Well, you have to look at more than just the four-chamber. So this is where we come to, as I said, this is one of our go-to views for assessing the right ventricle is actually the orthogonal view, the short axis of the ventricles. And what we'll see is that the mitral valve en face will be normal, but as we scan towards the apex of the heart, you start to see tricuspid valve. So that must be displaced. If it is so far down that you're no longer seeing mitral valve, then it's inferiorly displaced. So papillary muscles of the LV, and then here is our anterior leaflet. So that may be key. Also, some off-axis views may help us to assess that tricuspid valve in Ebstein's anomaly. Here is the diaphragm. And the right ventricle, this is anterior chest wall, and this valve clearly doesn't belong down here, and it clearly is leaking, so this is another instance of inferior displacement of the septal and posterior leaflets, Ebstein's anomaly. Of course, we have to look at the rest of the right heart. I'm not going to spend a lot of time talking about the RVOT, pulmonary valve, pulmonary arteries, and ductus arteriosus in Ebstein's, other than to say that once you've found a problem with the inlet, you do have to go ahead and look at the outlets with color and without. And here's a case of functional pulmonary atresia, no antegrade flow across a patent pulmonary valve. We know it's patent because it's leaking. And a complete assessment, of course, is going to look at the ductus as well, and the branch pulmonary arteries, which can be small due to lung hypoplasia in this condition if the cardiomegaly is massive. Tricuspid valve dysplasia has a similar physiology to Ebstein's anomaly, but as far as it being an inlet abnormality, there is no displacement of the valve in this condition. So septal leaflet is hinging at exactly the appropriate place in the crux of the heart, but the valve tissue itself looks quite abnormal. There's massive right atrial dilation and functional pulmonary atresia, again, with a pulmonary valve that is present but not opening and closing. Same patient with severe tricuspid regurgitation. So here the tricuspid regurgitation really starts at the annulus, not down in the body. That will also help you to make the distinction. But this septal leaflet really hinging at the appropriate place tells you this is tricuspid valve dysplasia and not Ebstein's. We would want to add Doppler information to our evaluation of the tricuspid regurgitation jet in all of these cases. Usually in Ebstein's and tricuspid valve dysplasia, the velocity is fairly low. Functional pulmonary atresia goes along with a low velocity tricuspid regurgitation, which would predict a right ventricular pressure that's less than systemic, so less than the aortic pressure, which in the fetus is a few millimeters of mercury above the gestational age. So if you have a 25-week fetus and the tricuspid regurgitation jet is 24 millimeters peak, then that ventricle is just not capable of opening the pulmonary valve. So we call that functional pulmonary atresia. It looks just like pulmonary atresia with retrograde flow in the ductus arteriosus, but this valve may in fact be patent in that type of patient. And so you have to be careful saying that the patient has Ebstein's or tricuspid valve dysplasia and pulmonary atresia unless you know for sure that the valve is not opening. And yet another example of severe tricuspid regurgitation in these lesions. Poor right ventricular function is also a problem sometimes with Ebstein's and tricuspid valve dysplasia. I don't have a good reason for that other than that the myocardium is probably abnormal in addition to the valve abnormality, and so we have to pay attention to the ventricular function once we see a problem with the inlet. And there again is our retrograde ductal flow telling us that this ventricle is not generating a lot of pressure, but again the valve is patent because it leaks. As far as prognosticating for these types of patients, there's been a lot of work done on this in patients who are neonates, have been born. This index was developed years ago called the Sellermeyer index, which is a ratio of the atrial area to the rest of the heart. That has also been applied in the fetus, as has cardiothoracic ratio, measuring the relative area of the thorax versus the heart, and putting that into multivariate analyses. This was an early single-center analysis from Boston where they found that independent predictors of death by multivariate variable analysis included right atrial area index, that's the Sellermeyer index, greater than 1, or the absence of antegrade flow across the pulmonary valve, like I showed you. So those predicted death in the fetal or neonatal period, but they only had 7 prenatally diagnosed patients. So there have also been attempts at creating scoring systems. This is from the UK, the so-called SAS score, and this is going to be in your syllabus, so you can look this up. I find this sometimes useful in that it clearly delineates the non-survivors from the survivors with a score, but often you end up right here and then you don't know what to do with it. So in the last couple of years, we've gotten together as a community and studied this together in this multi-center study of over 20 institutions combining their prenatal diagnosis of Ebstein's and tricuspid valve dysplasia, led by the group in Boston. We had 243 fetuses in this series, and essentially found the same thing that they found from the first paper that I showed you 2 decades ago, that the patients at the highest risk for neonatal or fetal mortality were those with pulmonary regurgitation, as well as larger tricuspid annulus size, pericardial effusion, and earlier gestational age at diagnosis were also predictive. But what about the fetuses that I showed you with very subtle tricuspid valve dysplasia? Those were picked up very early on. Are they going to do okay? Well, this was a question that we also asked of the same database, and Siddharth Tierney and Dov McElhenney and I, with some others, looked at just the 51 fetuses that presented prior to 24 weeks gestation, and we found that although most of them looked well at less than 24 weeks, they often, very often, I think 70% of the time, developed one of the markers for poor prognosis in the 3rd trimester. And the only predictor that we could look at early in gestation was the tricuspid valve annulus size. So the take-home message is that Ebstein's and tricuspid valve dysplasia represent a spectrum, but that early diagnosis does confer a worse prognosis, and they need to be watched serially. As far as therapeutic options, some need no therapy, depending on the severity of the physiology. Some may need tricuspid valvoplasty, 1.5 ventricle repair, PA ligation, BT shunt, Starnes procedure in the most severe cases where the right ventricle is completely excluded from the circulation. The best patients are those with the higher velocity tricuspid regurgitation. So if they have high enough right ventricular pressure and either functional pulmonary atresia or no pulmonary atresia, normal branch pulmonary arteries, and less than severe cardiomegaly, these patients may benefit from being delivered a little bit early, allow ductal closure or encourage ductal closure, either surgical or with indomethacin, and that can sometimes reverse the physiology, taking the baby from being a right heart dominant to left heart dominant, and the left heart is normal, so they can do well. The caveat is that those with pulmonary atresia, that's true pulmonary atresia, are going to be ductal dependent, and delivery is unlikely to help those patients. So working closely with your pediatric cardiologist to make sure that we know exactly what the physiology is crucial before we decide if this is going to be a univentricular or biventricular outcome and whether or not to deliver early. What about unguarded tricuspid valve? So I'll show you a few more abnormalities of the inlet. This is, as I said, unguarded tricuspid valve. There's no valve, there's no regurgitation, there's just something that looks like a right ventricle because there's a moderator band. Abnormal ductus venosus Dopplers should be taken with a grain of salt here because the low velocity A wave has been shown in patients with right ventricular abnormalities to not necessarily predict poor outcome. Here's a patient that looks very similar to the last, but this is Yule's anomaly, where the right ventricle is extremely thin. This is an adult with Yule's anomaly. This is right ventricle, not right atrium, that's being shown here. So this is a parchment-thin ventricle, and I have only seen one of these. The baby actually did fairly well and did not get progressively sick like the tricuspid valve dysplasia and Ebstein's patients. One more example of an RV inlet abnormality is tricuspid atresia. So here there's no tricuspid valve, normal mitral valve. There's usually a ventricular septal defect. And when we're describing tricuspid atresia, we have to pay attention to the outflows as well, because they can be normally related, as shown here, or they can be transposed, as shown here, where this is the ductus and this is a tiny interrupted aorta. So just looking at the inlet, again, not enough. Once you make the diagnosis of tricuspid atresia, you have to complete the fetal echo, pay attention to the outlets. But this is a fairly easy diagnosis to make with a small right ventricle and no tricuspid valve. Diagrammatically, there's an absence of a connection between the right atrium and the right ventricle, and these patients are cyanotic at birth to varying degrees depending on the size of the ventricular septal defect and the amount of pulmonary stenosis or hypoplasia. If they're transposed like the older one that I just showed, though, they are ductal dependent for their systemic blood flow like a hypoplastic left heart syndrome patient. So very important to complete the evaluation once you make a diagnosis of tricuspid atresia. So those are some of the inlet lesions. I want to move on now to the outlet, which is a fascinating structure as shown here, very smooth. There is a septomarginal trabeculation, or a muscular band that is continuous with the moderator band that we've already talked about. This structure is very difficult to actually appreciate on echo, but it's very easy to see here, and this supports the conus, which in turn supports the pulmonary valve. So the pulmonary valve in the normal right ventricle to arterial connection is going to be completely supported by this muscular conus, and this portion of the septum is together considered the outlet, including the valve. Quick quiz here. Which one of these is normal? This one? This one? This one? This one? Or all? Think about it. Okay, this actually is the only normal one. All of these four-chamber views are abnormal, and what I wanted to bring out here is that there's asymmetry at the atria, there's asymmetry at the ventricles in this patient, and there's sort of asymmetry at both here. All of these patients have actually an outlet problem with their right ventricle. They all have pulmonary atresia with intact septum. So here's one with a tiny right ventricle, small tricuspid valve versus normal. And again, left-right disproportion being the clue. When we investigate further, we see that there's tricuspid regurgitation and that this right ventricular pressure is quite high at 75 millimeters of mercury. So this tells us that this is not an inlet problem, this is an outlet problem because the pressure is very high. And here is a outflow view, RV outflow, pulmonary valve with just a tiny jet of antegrade flow. But as we get up to our 3-vessel trachea view, you can see what's already been pointed out, that one of the vessels is antegrade and the other retrograde. In this case, retrograde filling of the ductus arteriosus is our clue that we have a problem with the outlet, a problem with right ventricular outflow, in this case, pulmonary stenosis. So asymmetry of the atria also can be a clue to right ventricular outflow tract obstruction. This patient also has pulmonary atresia intact septum. And once we've identified that, we're going to do a complete echo and look at the outlets. So pulmonary atresia with intact septum is fairly uncommon. It is extremely uncommon to make this diagnosis in fetal life. It's often missed because the four chambers abnormalities can be a little subtle, as I showed you. It may be associated with variable degrees of infundibular, right ventricular, or tricuspid valve hypoplasia, so there's a spectrum of disease. And then it also may have coronary sinusoids, which are visible in fetal life due to the very high pressure and abnormal formation of the coronary circulation. Only sort of less than 50% are diagnosed prenatally, so this is something to work on. Certainly, the key is this color Doppler evaluation of the arches. So as I said, if there's retrograde flow in one of them, we have to think that there's some proximal obstruction. And so this is adding this to the screening views will certainly increase the diagnostic yield. At least that's the hope. And more of how we can see this retrograde flow in the ductus arteriosus. So if we're suspecting an outflow problem, we need to look at the infundibulum and the valve and the main pulmonary artery. The way to do this is a combination of sagittal imaging as well as the axial scanning, looking at the right ventricular outflow. Here's the pulmonary valve. We're almost in a three-vessel view, as Alfred said earlier. There's been some debate of whether this is a three-vessel view or an RV outflow tract view, but you certainly can see that portion of the infundibulum in this type of imaging. And then that's not quite sagittal, but off-axis view looking at the RV outflow tract will show us the infundibulum, and very nice look at the pulmonary valve. I think this is probably the best way to see it, and to assess whether the valve is opening and closing. As we see here, there is a valve present, but it does not open. Throughout the cardiac cycle, it's closed. So this is a good way to assess. Also, the traditional three-vessel view can be used. We can suspect pulmonary atresia, intact septum, if the pulmonary artery is much smaller than the aorta. And then, of course, our Doppler examination with a high-velocity tricuspid regurgitation jet that I already mentioned, and sometimes reversal of flow in the ductus venosus. As I said, this is a normal finding in patients with right ventricular problems, and maybe a tip-off, but should not necessarily panic the sonographer, because this does not necessarily mean the same thing as it would in a patient with a structurally normal heart. There are other qualitative and quantitative measures that we can look at with PAIVS, annulus size, ventricular dimensions, venous Doppler exam, rhythm, etc. I'm not going to go into all of those, but they are in your syllabus. We would want to measure the tricuspid valve because it does help us to predict our final palliation and predict short-term need for additional sources of pulmonary blood flow after a valvuloplasty done postnatally. There are various prenatal prediction models for whether a patient with pulmonary atresia intact septum is going to have one ventricle or two, and I think Dr. Reichik is going to cover some of that later on. So I will leave it at the fact that some people have looked at Dopplers and tricuspid valve size. The group in Boston looked at tricuspid valve size as well as growth and showed that the biventricular patients started out with a bigger valve, but it didn't grow, and then the single ventricle patients started out with a smaller ventricle, smaller tricuspid valve, and it also didn't grow. And then at San Francisco in our series, we found that tricuspid to mitral valve ratio gave us the best predictive ability as far as circulation at birth, but also that in the patients who had a larger tricuspid valve Z-score, if they had in fetal life moderate to severe tricuspid regurgitation or any pulmonary valve antegrade flow, that they were all biventricular. So it's a sort of a complex question of, once we've made the diagnosis, what is the outcome going to be? All of the predictive models include tricuspid valve size, but the phenotype with moderate to severe TR is almost never single ventricle. And then there's this problem of right ventricle to coronary fistulae that you'll sometimes see. These have been said to preclude a biventricular repair. Sometimes they're easier to see than others. Here's this to and fro flow in a dilated coronary artery. And we spend a lot of time in the fetal lab taking pictures of these, but honestly, and unfortunately, this is where the patients end up. This actually is me. During my fellowship in the cath lab. So sinusoids, I can't say much more about on fetal echo because it's really a cath lab diagnosis. So the basics for RV outflow obstruction is that the four-chamber is actually usually abnormal with discrepancy. There may be tricuspid regurgitation. The three-vessel view is going to be key. Color Doppler is also going to be key, and the venous Dopplers can be abnormal. Our challenges are that there are many morphologic variations. Neonates will all be ductal dependent, but management strategies depend on the nature of the outflow obstruction, the adequacy of the right ventricular structures, and the potential for ischemia. And so being able to do a detailed evaluation of that infundibulum pulmonary valve and then the physiology is key. I want to talk about the body of the right ventricle because that is the third part that's very important to evaluate and is often not discussed. I'm not going to talk about the ventricular septal defects. Those were already covered, other than to say that they can occur in the inlet. We can have inlet and inlet muscular. We can have body muscular defects anywhere in here. We can have outlet ventricular septal defects. So understanding the tripartite nature and being able to describe exactly where the ventricular septal defect is can be very important for surgical planning and for risk for aneuploidy and deletion syndromes. When we look at the body of the right ventricle, we need to look at the muscular thickness, at the moderator band, at the function of the ventricle. And I want to point out that looking for that moderator band is just so important. These are two patients who both have transposition of the great arteries. This is actually DTGA, with right atrium connected to the left ventricle in the patient on the left and connected normally in the patient on the right. So pay attention to that ventricular morphology. Make sure the body of the right ventricle really is normal before you call it normal. We can see the moderator band here, and a little less obvious that the crux of the heart is also mirror image in that patient. As far as ventricular function, right ventricular dysfunction often catches your eye, but there's a problem with coming up with a differential diagnosis. So these are the things that I can sort of think of. There's inherited cardiomyopathies, there's acute ductal constriction or closure that may cause a high afterload, twin-twin transfusion also causing high afterload, agenesis of the ductus venosus with volume overload, arterial calcification, which causes a high afterload and coronary disease, and then antibodies, severe IEGR, renal disease, and other can also all affect the right ventricle. The cardiomyopathies may affect the right ventricle more severely and earlier than the left ventricle. And so when assessing the body of the right ventricle, we may see something very poor function. This actually was a patient, the pregnant patient had dilated cardiomyopathy and her uncles had had heart transplants. We think of these as being left heart diseases, but in her fetus, it was almost exclusively right heart in phenotype. This is the same fetus. So this right ventricle, a few weeks later, really not ejecting at all, and that fetus succumbed. And then finally, look at the muscle itself. Non-compaction cardiomyopathy is increasingly being recognized. This is a patient who presented very high BMI, uneventful pregnancy until she presented with this florid hydrops. We actually suspected ventricular non-compaction, and so arranged for an autopsy at the time of the fetal demise, and the diagnosis was was confirmed. Here's another patient, different patient, who has obviously bradycardia from heart block in conjunction with non-compaction cardiomyopathy, but you're not going to see this unless you look for it. So if there's a problem with the fetus, hydrops, etc., look at the ventricular myocardium. There's also ventricular myocardium being too thick, and again, this may affect the right ventricle at least as much or more than the left ventricle, such as in this patient with Noonan's. And so going ahead and doing genetic testing in these patients is important. Assessment of the hemodynamics is also important. There may be inflow abnormality, so there's a diastolic function problem, as well as obliterative right ventricular outflow tract obstruction. So we have afterload and diastolic dysfunction causing problems for these fetuses. Very poor prognosis when they present in fetal life. And then arterial calcification, just because I didn't know where else to put it, but it can present as what appears to be a right ventricular function problem. The dead giveaway is the outlining of the arteries, including the coronary arteries, and severe diastolic dysfunction, tricuspid valve inflow pattern being very abnormal there. So to summarize this whirlwind tour of the right ventricle and its three parts, there's an inlet, body, and outlet. Abnormal size is often the cue to look at these three segments, and they do need to be looked at sequentially and, as Tracy said and Alina said, in a protocolized manner. But if the ventricle is too big, think about regurgitation. Too small, think about obstruction. And inlet and outlet abnormalities may be seen together, so use your physiologic parameters, your Doppler, your color Doppler, to decide what the primary problem is using those Doppler clues. Abnormal function and those structural abnormalities of the body of the right ventricle may be primary from genetic abnormalities, in which case the prognosis is very poor, but genetic testing is indicated and counseling is indicated because of recurrence risk. They may also be secondary. That's also bad, but in cases, for instance, twin-twin transfusion, they may get better with treatment. So understanding the etiology will help to understand the natural history. Thank you very much.